Hello, this video is a supplemental video to your Module 1 content. This is about the care of the respiratory patient with complex respiratory disorders. So as part of your transition from LVN to RN, you'll be enhancing or expanding your assessment skills and also taking care of more complex patients. So I want you to remember that you have to collect subjective and objective data. And that part does include the history, the patient's history. You will ask them their chief complaint, and you've got to include things like, when did it start feeling like this? What were your symptoms? What are your symptoms? Have you had cough? Are you producing anything? What makes it better? What makes it worse? Do you have any pain? Where is it? What is it like? And then you've got to identify the related elements. So if it does get better and worse, what are the things that aggravate the condition, and what sorts of things alleviate the condition? You've also got to be sure to talk to the patient about their medical history and even their family history. You want to assess their lifestyle, their potential exposure at their job, any smoking or vaping, and any other allergens, any anxiety, anything like that. And while you're doing this, you're going to be observing the patient and watching how they seem to be feeling when you're doing your assessment. For the physical assessment, you've got to provide patient privacy. And remember, you're going to need your stethoscope and your eyes and ears and hands. It should be an organized exam. You start with inspection, where you just look. Then next you touch for palpation. You might perform percussion, where you tap. And then there's auscultation, where you listen. You're going to identify abnormalities using anatomic landmarks. For inspection, you're going to observe the patient's posture and breathing pattern. Intercostal muscles are the muscles that go in between each of the ribs, and a slight retraction or pulling in of the intercostals is normal, but a marked retraction would indicate blockage, that the muscles were having to pull really hard to not create much movement in the ribs. If a person is forward leaning, for inhalation, they're suffering from air hunger, where they feel like they can't get enough air. If a person is pursing their lips, they might be suffering from COPD. And if they're flaring their nostrils, they might also be feeling air hunger. Remember, your nose has narrow passageways, and so a lot of times if people are having difficulty breathing, they're going to use their mouth because it allows for larger volumes of air to pass through. But they might have their mouth open and have nasal flaring. You're going to listen for audible breath sounds, anything that you can hear when you enter the room or as you get close to the patient. A normal respiratory rate is anywhere between 12 and 20 breaths per minute, and it's usually smooth and even. You need to note the AP, or antero-posterior to transverse diameter. Normal is 1 to 2, which means for every 1 inch of depth of the chest, there should be 2 inches of width. The overinflation or barrel chest indicates COPD, and the ratio, the antero-posterior to transverse diameter relationship in a patient with COPD is typically 2 to 2. Inspiratory, that just means that it's as deep as it is wide. Inspiratory expansion should be symmetrical. If there's asymmetry, that means maybe there's a collapsed lung, or extrapleural air, which just means air out of the lung space. And it could even mean that there's fluid or a mass, like cancer or a tumor. It could be a non-cancerous tumor. If you have bulging intercostal spaces, that usually means there's an obstruction or emphysema. Here's a picture to help you see AP to transverse. So this is about half as deep as it is wide. And then in a patient with barrel chest, it's about the same, about the same depth as it is width. So for breathing patterns, eupnea, or like a good normal breathing pattern, is going to appear like this. The depth is consistent and the rate is consistent, anywhere between 12 to 20 breaths per minute. For tachypnea, the depth is pretty much similar to eupnea, but it's uh, an elevated rate, increased, a rate over 20. This can be caused by lung infection like pneumonia, by pulmonary edema, acidosis, septicemia, or even pain. Bradypnea would be a decreased rate. And so look, the depth is normal, but the rate is slow, less than 12 breaths per minute. This can be caused by a lot of things. Oftentimes, increased intracranial pressure will cause bradypnea or a drug overdose. Okay, next is Kussmaul's respirations, and that's when there's an increase in the rate and the depth of the respirations. So this is going to be a respiratory compensation for severe acidosis, like DKA. Every exhale, you're breathing out CO2 or acid, and so your body wants to keep doing that and really exhale as much acid as possible. Lastly, we have Cheyne-Stokes respirations, and they are of varying depth, as you can see, and then also periods of apnea where there's no breathing. And so this is called the death rattle, or sometimes it's called agonal respirations. So when we assess, let me move myself here. When we assess patients, we are going to be looking at tracheal position. In this patient, you can see that their neck is not symmetrical, but we are going to palpate with our hands, and I'll talk more about that here in a little bit. This particular patient is not normal. Their trachea is not central or midline. They do demonstrate a deviation. Deviations can occur due to a pleural effusion where one of your lungs has collapsed. It can be caused by a tension pneumothorax. It can even be caused by atelectasis. So this woman has tracheal deviation to the left. Inspection. You are going to inspect their chest. There are some conditions. There's pectus excavatum, or funnel chest, and it's where the lower portion of the sternum is depressed. And if it's severe, it can cause heart damage, because where does the heart sit? It sits right behind that breastbone. And so it might limit the space that the heart can take up and cause decreased cardiac output. We know that's an issue. Another thing that we can sometimes see is a pigeon chest, and that's kind of the opposite. It's where the sternum protrudes outward, and you end up having an increased antero-posterior to transverse ratio. So for these, I know for pectus excavatum, sometimes a surgery can be performed where the chest is manipulated and a metal bar or rod is put in, and it helps the chest kind of create a more natural shape and provides more room for the heart. For a funnel chest, I have seen an article online where a boy in England did have surgery where they also manipulated his ribs and his sternum, and then had him wear a brace for something like a year, and it did cause his bones to heal and reform in a more natural position. For posterior inspection, you can be able to see if somebody has scoliosis which would be a lateral or rotational curve of the spine. Complications of scoliosis on the respiratory system is that it can restrict the lungs, and you might end up with a restrictive lung disease. And of course, there's back problems. There's also kyphosis or hunchback, where the back of the thoracic spine is curved, or lordosis, which is called sway back as well. And it's an anterior curvature of the lumbar spine. Let's look at some photos. There's different types of scoliosis. This one doesn't show any of the twisting. Did you know that in Texas, registered nurses can take a spinal screening certification course through the Department of State Health Services in order to not only be able to screen for spinal abnormalities, but they can also apply to be instructors and train other people how to screen for spinal abnormalities. These screenings are required in Texas schools, so that is one way that registered nurses can help in their communities. Scoliosis can be treated with surgery or back braces. We're not doing a musculoskeletal lecture, but since the content mentioned it, I thought I'd bring it up. Kyphosis, this shows a kyphotic spine, or is a thoracic anterior curvature. And then we've got lordosis. And so this picture over here is a picture of a child demonstrating lordosis, but also pregnant women may demonstrate an increased lordotic curve because of the weight of their belly, but also because the hormones of pregnancy can cause some laxity of the joints and allow for increased movement. The assessment for the respiratory system doesn't just include assessing lungs and chest, it also includes looking at fingers. And you see here in this photo clubbing, which can indicate a fibrotic lung disease, congenital heart disease with cyanosis, COPD very often, sometimes emphysema and chronic bronchitis. So you can see the curve of the nail is greater than 180 degrees, okay? In a normal finger, it would be 180 degrees where it's just flat. But this curves downward. And then also there's hypertrophy of the distal phalanges, where basically it's just larger than it should be. And I don't know why that is. I don't know why that happens. Maybe one of y'all knows. So we're going to assess the use of accessory muscles. I did talk a little bit about the intercostal muscles, but there's also the sternomastoid and pectoralis major. You've got your latissimus dorsi and serratus anterior. And then to exhale, if you're having to push against a pressure or something, to exhale, you've got your abdominal muscles. The prefix dis, as in dys, means difficult, and the last half of the word pnea is related to pneu, which is Latin and Greek for lungs. So this word technically means something like difficulty lungs, but we know that it means difficulty breathing in healthcare. So it's associated with cardiac and respiratory diseases, and difficulty breathing in an otherwise healthy individual that comes on very quickly might be caused by a pneumothorax. Sudden onset in an ill or postoperative patient could indicate a pulmonary embolism, a blood clot in the lungs. I love these little pictures. So the 6 P's of dyspnea are a possible foreign body in the upper airway, some pulmonary bronchial constriction, maybe inflammation or something, a pulmonary embolus, a blood clot in the lung, maybe a pneumothorax where the lung has less space, pneumonia, or pump failure, meaning heart failure. So those are the 6 P's of dyspnea, the 6 most common reasons that somebody's going to have difficulty breathing. Orthopnea means difficulty breathing when you are lying back or lying flat. So somebody who has orthopnea is going to be sitting up or leaning over like the person in the picture, because that relieves their difficulty breathing, and it's associated oftentimes with heart failure or COPD. You need to assess your patient's sputum. You need to assess whether or not they have sputum, and if so, you need to ask the quality and characteristics. So is it thick or thin? Is it any potential specific color? And then you want to memorize, if you don't know already, you've got to learn the description of the different types of sputum and then what they could potentially indicate. We're also going to palpate during our respiratory assessment, and the purpose of palpation is to provide further assessment of abnormalities that are suggested by the history or by our assessment so far. So we're going to look at the skin and subcutaneous structures. You're looking for any blue skin that would indicate they're not getting very much oxygen, and you're going to feel their skin. They might have subcutaneous air. We'll talk a little bit more about that here in a minute. You're going to assess thoracic expansion. I do have a video posted about from YouTube about that, but you can search your own YouTube videos if you want. You're going to assess tactile fremitus, and I did post a video about that, but also I posted an article about why we should not be asking our patients to say the words 99.99. So that's really interesting. Take a read for that. We need to assess tracheal position, which we already talked about, but we're going to do that through palpation. We're going to palpate the chest wall, checking for tenderness, masses, or lesions. And then we're going to palpate the sinuses. You see in the picture there the location of where you're going to put your thumbs and how you're going to hold your patient's head. And basically you push in and up for both of them. Crepitus would be like popping or cracking that's heard under the skin, and a crackling would be like a Rice Krispies in subcutaneous tissue, and you'll feel that through palpation. I've taken care of a patient that arrived to the emergency room, and they were intubated and out in the field, and they did end up being coded a couple of times, and at any rate, I noticed the patient was developing some swelling or like a rapid increase in size in the lower abdomen and the upper leg. And as I palpated it, I discovered that it was like Rice Krispies. And what had happened is somehow there was an air leak. Whether it was in the airway or the lungs, there was an air leak occurring, and that air had found its way to the lower portion of the patient's abdomen, and then it was being deposited in their lungs. So when we stopped bagging them, that Rice Krispie kind of area stopped growing. So it's another way, or that's how we can see subcutaneous emphysema or what seems like Rice Krispies. Next, we're going to auscultate. So we're going to use our stethoscope, and we're going to use the diaphragm, which is the large size. It is used for high frequency sounds. That's what we're going to use for the respiratory assessment. You place it firmly against the patient's body, and you use a systematic pattern. You should do it the same way every time. You have the patient breathe slowly and deeply through the mouth, and you listen to the sounds. I'm a big believer that the more sounds that you listen to, the more familiar you get with how they should sound. And so when you go to clinical, listen to everybody's heart and lung sounds and just become more familiar with normals. And when you're familiar with normals, you will recognize an abnormal quite easily. Here are the lung fields that we're going to listen to, both anteriorly and posteriorly. Sometimes you might see posteriorly that it's just kind of like the same distance apart all the way to the bottom. Here is a description of different types of breath sounds. So bronchial sounds are going to be heard kind of over the trachea, and in the back it'll be over the upper right lung field. You're going to hear bronchovesicular sounds at the front, kind of at the first and second intercostal space at the sternal border, and then in the back, you're going to hear it between the scapulae. And then the vesicular sounds, you can hear those over the peripheral lung. Adventitious breath sounds just means like extra breath sounds, things that are not, quote, normal. So fine crackles are air passing through moisture in the small passages and alveoli. So you hear it at the end of inspiration when somebody breathes in, and they're not continuous. And you can ask the patient to cough, and they don't go away. It sounds like hair that's being rolled between fingers. Medium or coarse crackles would be air passing through moisture in bronchioles. It's the same as above, but it just gets louder, has a moister sound, and you might hear it at early to mid inspiration. Next, you have rhonchi or wheezes, and that would be air passing through small air passages, narrowed by secretion, swelling, tumors, asthma. These are continuous sounds and oftentimes heard on expiration. They are high-pitched, musical, and wheezing. So if you have difficulty, you recognize that something is abnormal, but you are not sure which sound it is, please just compare it to descriptions of the different sounds and kind of, find ones that make sense. Did the sound happen during inspiration or expiration? Is it continuous? Is it intermittent? Um, and then sometimes you can even look at patient history and kind of figure out maybe what type of sound you're listening to. Friction rubs sound like the rubbing together of inflamed and roughened pleural surfaces, or actually that's the origin of that noise. But what it sounds like is a creaking or grating quality. It's heard both in inspiration and expiration, and you hear it best at the lower anterolateral chest. And there's really no change with cough on that one either. Stridor is a partially obstructed trachea, and that sounds like a crowing sound. I'm not going to read all of this chart to you, but there are dozens of charts like this all over the internet. I tried to look in your Lewis text for one, and I didn't find one. Maybe y'all can find one, but at any rate, this is going to be helpful. Let's talk a little bit about oxygen administration. So, oxygen might be initiated on an unstable patient, and we can initiate oxygen without a physician's order based on patient symptoms, but we should request a physician order as soon as we can. Physician orders for oxygen administration do have to have objective parameters like, to keep the pulse ox greater than 90%. Normal pulse ox is going to be 95 to 99%. And the normal for a patient with COPD is 88 to 94%. If you have a patient who has COPD and you have them on supplemental oxygen and their pulse ox is 99%, that's no good. You might be causing them oxygen toxicity, and so you need to back off on the oxygen. CPAP and BiPAP are oftentimes initiated for patients with obstructive sleep apnea. And CPAP is continuous positive airway pressure therapy. So imagine if you were holding a balloon and you squeezed, and then when you were letting go, you didn't let go all the way. You still kept some tension there. It's a little bit like what CPAP is like. And CPAP helps because it helps people sleep better at night, and then they feel better during the day, and they're not as sleepy during the day. And then it's also great for heart health. I do have a close family member that ended up having a dissected aorta due to untreated uh, obstructive sleep apnea. So there are risks for not treating chronic conditions. BiPAP is bilevel positive airway pressure, and the inspiratory positive airway pressure, when if I was squeezing a balloon and I squeezed it in, might be the same as like a CPAP level, but then it's a lower expiratory pressure. So as it lets go, it is allowing the patient to exhale more easily. It's not going to provide um, the same amount of tension on the exhalation. A lot of times, a pulmonologist or other provider might order a pulmonary function test or abbreviated PFT. These are non-invasive. The nurse doesn't need to do any special preparation for the patient. Oftentimes, these are used for people with asthma, emphysema, or other chronic lung diseases. Chest x-rays are taken, sometimes they're taken out in the community, like maybe at a nursing home, but oftentimes you're going to see them in the acute care setting. They're non-invasive, they don't require any special preparation by the nurse, and they do show air, fluid, infection, and cancer. On an x-ray, black would be air. This is an x-ray of what community-acquired pneumonia looks like. It's pneumonia that starts at the base of the lungs, at the very bottom, okay? This is an x-ray of COVID pneumonia. So I did have a family member during the pandemic. They wanted to know how the doctor knew what type of pneumonia their family member had. You know, how come they know it's not regular run-of-the-mill pneumonia? Well, because community-acquired pneumonia looks just like this in pretty much every patient. But COVID pneumonia looks I think I heard one person say like a ground glass infiltrate. Like it looks like somebody it's just hazy all over, isn't it? Sometimes we can detect cancer on x-rays. You can see here is a clean x-ray per se. And then here we can see that there's a mass in the right lung. This x-ray demonstrates tension pneumothorax. So the lung is collapsed. There is no vasculature seen on the x-ray. This is the side. This is the side with the collapsed lung, okay? See, there's no blood vessels there. This is just airspace. This lung is not inflated. Probably going to see a tracheal deviation in this patient. And this is a pleural effusion. So there's fluid filling the space where there is no lung tissue. The lung has decreased in size and created a space, and fluid has filled it. A VQ scan is actually called, it's a ventilation perfusion scan, but it is abbreviated VQ scan. And this is a nuclear medicine scan. So the patient does have to have uh, um, administration of a radioactive substance. So this scan checks what happens to the air that you breathe when you breathe in radioactive material, and then it watches what happens to the blood flow through your lungs um, when the radioactive material is injected in your blood, okay? So you do need IV access for this as well, and it's used to diagnose PEs most often. They'll also draw blood work to check a D-dimer value, and D-dimer is a substance that dissolves clots. So if you do have clinical signs and symptoms of a pulmonary embolism and you have an elevated D-dimer, it's, you probably have a clot. Your body is trying to break that clot down. They're also going to get chest x-ray, a CT, and pulmonary angiogram, and they might get an MRI. It really depends on the patient and the provider. So these are what the results of a ventilation perfusion scan look like. On the top is the ventilation. So this is when the patient inhaled a radioactive substance. Where does the air go in their lungs? Okay. And at the bottom shows the perfusion results. And this means when the radioactive dye is injected into their blood, where does their blood flow in their lungs? CT scans are oftentimes orders that are written for a patient with lung issues. So a CT is non-invasive, and it's just a series of two-dimensional cross-sectional images. and it's going to evaluate your lungs for conditions like pneumonia, cancer, PEs, or any other damage that comes from smoking. So a CT might look like this, and you see this is kind of like plain. You can tell maybe there's some like mild changes here compared to the tissue around it. And over here you can see though that there's definitely something going on. CTs are pretty detailed. An MRI is non-invasive as well, and it does provide detailed pictures of the tissue and lungs. It's not quite as good as CAT scan, but it does help prevent exposure to radiation, which is important. MRIs can be an alternative to angiography as well if the patient can't have the dye. So this is what MRI results look like for some conditions. Then we have PET scans, and so PET scans are used in combination with a CAT scan to diagnose lung cancer. The patient will need IV administration of a radioactive substance, and you do need to let the radiologist know if the patient is pregnant or breastfeeding. So this is a CT alone. You can see there's some sort of mass there, but if you do a PET with it and it's cancer, it's going to light up. Oftentimes, doctors will order ABGs to be drawn on a patient. ABGs use blood from an arterial stick in order to evaluate um, how well your respiratory system is able to function for your body. Some hospitals do have handheld devices in the emergency rooms or on critical care units that can give ABG results really quickly. And others, you have to send the blood down to the lab to get results. We will do ABGs later in the program. If not before, you will definitely learn them during your level 4, which is your final semester before you graduate in critical care. So your doctor might order some blood tests if you're having lung problems or respiratory issues, and the most common ones they're going to look at would be a CBC, which includes white blood cells. That'll indicate an infection if they're elevated. And also they're going to look at RBCs and just make sure that you have enough RBCs to be carrying the oxygen. If you are anemic or you have low RBCs, it might be difficult for your body to transport oxygen around. You will also sometimes have to draw blood cultures on a patient, and we do get 2 sets of blood cultures just in case. And that what they're looking for would be sepsis that is caused from some sort of respiratory infection, so a septic pneumonia. Now, that's it for your supplemental video on respiratory assessment and treatment modalities in the acute care setting. And if you have any questions, please contact me. If you're having difficulty with the Evolve case studies, please let me know. I would love to help you. If you're having trouble, chances are there are other people having trouble as well too. You can also reach out to a friend and see how they're doing on theirs. But please make sure the work that you turn in is original to you. Okay? Thanks so much. Have a good afternoon or a good day. Goodbye.